Hello, my name is Islam Shireen. In the next few minutes, I'll talk about how to apply the evidence about the CNV-related macular edema in our everyday clinical practice. It's well known that there are several causes of CNV, the most important of which are the neovascular age-related macular degeneration and the myopic CNV. The traumatic CNV and other causes do exist. So we'll start to talk about the neovascular AMD-related macular edema. We need first to know that just the presence of pigment epithelial detachment is not an indication of surgery. There should be subretinal fluid accumulating over the retinal pigment epithelium or intraretinal fluid to initiate the treatment. So one of the questions that is frequently asked is whether the type of CNV matters. We know that there are two main types of CNV, type 1 or previously known as occult CNV, in which the CNV tissue is present underneath the retinal pigment epithelium, or type 2 CNV, in which the CNV tissue invades through the Brooks membrane and grows either in the subretinal space, and it is known as the classic CNV. Kim et al. Performed a large meta-analysis and concluded that in both groups, with those with type 1 and type 2 CNV, in both groups the best corrected visual acuity improved at the 6 months visit and then gradually worsened over the next 2.5 years. For type 1 CNV, there was a statistically significant change in the best corrected visual acuity, so we can talk about improvement of the vision. This is not the case with type 2 or the classic CNV, in which we talk just about stabilization of the vision. And in general, they found that type 1 CNV, the occult one, achieved better best corrected visual acuity than type 2 CNV throughout a 2-year study period. A second important question is which dosing regimen is better. The meta-analysis performed by Lanzetta et al. Reported that the best outcomes in the clinical trials were reported in those who are using a fixed dosing schedule. However, there are some cons with the fixed dosing schedule, including the high clinic and patient burden and increased risk of over-treatment or under-treatment if the interval between the injections is less or more than the interval of the disease activity. In most of the fixed dosing schedule, we give initial 3 monthly injections, then we continue monthly injection with bevacizumab, the Avastin, ranibizumab, the Lucentis, or we go for bi-monthly injection with the aflibercept, the Eylea, or we go for quaternary dosing with brolucizumab, the Bovun. Another dosing regimen is the PRN or Prorenata, or treatment whenever needed. In this regimen, the patient will come for a visit every 4 weeks, and treatment will be initiated only on certain criteria indicating the recurrence of the activity of the condition, either by the visual acuity, the OCT, or the fluorescein angiography. As you can see in the follow-up OCT of this patient, there is a new pocket of subretinal fluid. The main problem is that even with the clinical trial, some physicians will not adhere to the treatment criteria, and this will lead to under-treatment. This is an example of the disadvantage of the PRN treatment. So if the patient received the injection at week 0, he or she will come back at week 4 and the disease is still inactive, then she will come back 1 month later. The duration of the drug lasts for 6 weeks, and then there are 2 weeks interval of activity of the disease. If this will go back to be repeated again and again and again, the patient will lose a bit of vision with each of those reactivation incidents. The third regimen is the treat and extend regimen, in which we go for fixed monthly dosing of injection of anti-VEGF till the disease is inactive, and then we start to increase the interval progressively until reaching the interval in which the disease is becoming active. This means that the disease activity occurs somewhere between this interval and that interval, so it occurs at this part. Then we continue injection as an interval slightly shorter than the interval at which the reactivation happened. we need to notice that this is a proactive way of treatment. The patient will get the injection at every visit, regardless of his or her visual acuity and OCT results. Yin et al. Performed a meta-analysis on a total of 8,847 patients from 18 randomized clinical trials, and they reported that the difference between the various anti-VEGF inhibitors were not significant, so no one was better than the other. And in addition, they reported that patients with lower number of injections per year achieved worse visual outcome. Another important study is the AURA study. This is not under randomized control trial. It's a real-world study conducted in several countries in different continents. They reviewed retrospectively the files of more than 2,000 patients of neovascular AMD treated with ranibizumab. They reported that the visual acuity improvement was 2.4 letter in the first year and 0.6 letter in the second year. This means that we talk about stabilization of the vision rather than improvement. And the mean number of injections was 5 in the first year and 2.2 in the second. If we look at the difference between the countries participating in this study, we can learn that countries with smaller number of injections per year, in these countries the patient achieved worse visual improvement in comparison to countries with larger number of injections. This indicates the importance of number of injections per year. And in addition, it's not only about the number of injections, but about the degree of follow-up of the patient. So if there is a strict follow-up and larger number of follow-up visits, this will ensure that there is no great deterioration of the best-corrected visual acuity of the patient. In addition, if we look at the subgroup analysis of U1 and 2, they highlighted the difficulty to regain vision once it had been lost, and they reported that patients treated until stable and only retreated when the vision deteriorated never caught up in terms of visual acuity against those who were proactively treated. Again, here we are talking that we need to adopt more the treat and extend more than the PRN in patients with neovascular AMD. Now we will move to talk about the myopic CNV. In a large meta-analysis performed by Glax et al., they reported that the anti-VEGF was the most effective treatment option for myopic CNV. It was more effective than laser photocoagulation or PDT or any other way of treating the CNV. They reported that the different anti-VEGF agents, bevacizumab, aflibercept, and ranibizumab, achieved similar improvement of the visual acuity. However, aflibercept seems to lead to a greater decrease in the central macular thickness. Analysis supported the use of 1 plus PRN. This means give 1 injection and then follow up the patient and give more injections whenever needed, because patients who had 3 initial injections, they achieved better improvement of the visual acuity and the central retinal thickness. However, the change was not visually significant. Thank you for listening to this lecture. I hope it added something useful to you. I'm looking forward to seeing you again in upcoming lectures.